us for the second webinar in the COMET 8 series. Many of you will know that this is replacing what should have been our face-to-face meeting at the wonderful Maritime Museum in Liverpool, which sadly couldn't happen this year. But we do hope to see you in person soon. So today's webinar will be co-presented by myself. I'm Paula Williamson. I chair the COMET Management Group, but also my co-presenter, Sarah Gorst, who's a Senior Research Fellow with COMET, but is also currently the COMET Project Coordinator, covering maternity leave for Liz Garden. So what I wanted to do, first of all, so Sarah has muted everybody to start with. When we get to the questions at the end, which please do put into the chat. Sarah's monitoring the chat and we'll try to look at them systematically at the end. Hopefully we'll have about 15 minutes at the end for questions. And we can unmute you at that point if you wish to let us see your face when you ask your question. Okay, so I'm just going to share my screen. Hopefully, is that working, Sarah?
Yeah, fine.
Okay, thank you. All right, so we've realised that it's been over 10 years since COMET started, and actually many people who give talks on behalf of the COMET Management Group very quickly skim over the actual problems that COMET set about trying to overcome. So I thought it might be helpful just to spend a few minutes just reminding everybody of what those problems are, as they still are prevalent. So this is a sort of outcome matrix which many systematic reviewers will be familiar with. So when we're looking at clinical trials and looking at the outcomes that they've measured, often we might put this together where the rows are trials within that systematic review and the columns are the outcomes that you might be seeking information about. And what you notice in this matrix is where there's a Y, that means that outcome was measured and reported, at least to some degree. But where there's a gap, it means that you don't know whether the outcome was not measured at all, or whether it was perhaps measured but not reported, possibly because of the results for that particular outcome. A problem that is now referred to as outcome reporting bias. But even if an outcome has been measured and reported, there is another problem that you may see, and that is how the outcome has been measured. So in this graphic, what you can see is in a systematic review of studies of breast reconstruction surgery, you will see if you take symmetry at the top, over 80% of the studies did measure symmetry as a sort of outcome domain, but the way in which symmetry was measured was by one of 4 different approaches: clinical, photographic, geometric, or patient reported. So this is a very nice graphical display of the problem across trials looking at the same question, that not only does the what that's being measured vary, but also, even if the what might feel the same, how it's being measured varies. There's also the issue of the relevance of the outcomes. So who is deciding which outcomes are important to measure? In a review by CADAS, which is the Canadian group looking at clinical guideline development, they looked at 30 of their clinical guidelines, and on their guidelines panel, they always involve patients, they include patients. They asked the patients on those guideline panels what outcomes were important to them. And what they noticed of the outcomes that patients said were important, they then compared those to the outcomes in the primary studies that the clinical guidelines were being based on. And they found that only half of the outcomes that were important to patients had been measured in even one of those primary research studies. So there's a mismatch between what is being measured in research and what matters to patients as an important stakeholder group. So in summary, problems with outcomes, we see inconsistencies in the outcomes that are included for a particular health condition. We see variability in the way in which those outcomes are measured. This can lead to a problem of outcome reporting bias. So what you see in the literature is a biased representation of the truth. This will obviously lead to difficulties for decision makers when they're trying to compare and contrast the results of different studies. And studies often lack outcomes that are most important to patients and other stakeholders who are making decisions about healthcare. So one potential solution to this set of problems is a core outcome set. And this is the definition of a core outcome set for trials. You'll hear later that there are core outcome sets being developed for other types of studies, other types of work. But for trials, it is an agreed, standardized set of outcomes that should be measured and reported as a minimum in all clinical trials in specific areas of health or healthcare. So the as a minimum is underlined because we fully expect trialist researchers to be measuring some other outcomes as well on top of these key agreed core outcomes. To help promote the development of core outcome sets and their uptake, when COMET was founded in 2010, we realized core outcome sets are not a new concept. They weren't a new concept then. But it was quite difficult to find them in the literature. So what we did was we set up a database, which on our website is sort of like the top left-hand corner. And it's a publicly available searchable database that contains as much as we know about core outcome sets. At this point, I'm going to pass you over to Sarah, who's been absolutely instrumental in populating that database over the last 5 years. Sarah.
Right, I'll just swap the screen over. Right, okay, so can everyone see that? Is that okay, Paula?
Yeah.
Right, so hi everyone, my name is Sarah Gorst, and as Paula said, I'm a research associate based at the University of Liverpool. I've been a member of the COMET team for coming up to 6 years now, and my role involves methodological work relating to the development and the application of core outcome sets. But one of the main elements is ensuring that the COMET database remains up to date. So to do this, we undertake an annual systematic review of core outcome sets. Now, the first review was undertaken in 2014, so this was just before I joined COMET, and it identified all core outcome sets that have been published to date. Since then, we've conducted 6 updates, and these all identify core outcome sets that have been published in the previous year. So in total, there are 370 published studies relating to the development of 447 individual core outcome sets. And I am quite familiar with all of these, so much so that Paula jokes that core outcome sets should be my mastermind subject, and sadly, she's probably right. But it's not just the review is how we identify them. So we also receive database alerts and through contact with core outcome set developers. So as soon as we're made aware of a core outcome set, we add it to the COMET database. And in addition to the published studies, there's also over 300 ongoing core outcome set studies in the database. So here's an example of a core outcome set study in the database. And this was developed for acute respiratory failure. And as you can see down the side, there's a series of linked studies. And these include things like systematic reviews of outcomes or qualitative work on patient perspectives, and these contribute to the development of the core outcome set. So these studies are also included in the database. Now, as Paula mentioned, core outcome sets tend to focus on the what, so what outcomes are most important to measure. The next stage is identifying how to measure the outcomes within the core outcome set. So you can see here, there's a study for this group. They also recommended measures for the outcomes within the core outcome set. And so we also include these studies in the database as well. So as I mentioned, we've got over 300 ongoing studies registered in the COMET database as of yesterday, 318. And the reason we registered ongoing studies is basically to make people aware that this work is ongoing. And this avoids duplication, so multiple groups developing the same core outcome set at the same time. So when a developer contacts us, we have a look to see if there's any similar work ongoing in that area. And if there is, we offer to put the groups in contact with each other. And there's examples of groups collaborating in the areas of delirium and gastroschisis. But we don't force groups to collaborate. So we don't own core outcome sets. So people can still develop them in the same area. What we ask is that when people are registering a core outcome set, if it is very similar to another core outcome set, we just ask them to explain the rationale for the need for this other work. So we've looked to see how many of the published core outcome sets were pre-registered in the COMET database. So if we look back to 2013 to 16, it was just over a quarter of studies have been pre-registered. And this didn't change much in 2017. But if we look to 2018 and 2019, this rises to 70% and 76% of studies being pre-registered. And so this is great, but there's still a number of studies that aren't being pre-registered. And so we do encourage developers to register them with us. Now, when developers register their core outcome sets in the database to let us know they will be developing them, we also highlight the various resources that are available to them. And these include things like COSSTAD. So this is the core outcome set standards for development, and it's the minimum standards for the design of a core outcome set study. These can also be used by the users of core outcome sets to decide whether a core outcome set is relevant and has been developed using a reasonable approach. Then we've got the COSSTAP. So this is the core outcome set standardized protocol items. So a checklist of items that are considered essential when developing a core outcome set protocol. And we've got COSSTAR. So this is the core outcome set standards for reporting. So it provides guidance on the final reporting of the core outcome set. And all of these guidance documents have been developed through international consensus. We also have the COMET Handbook, and this was developed by the COMET Initiative. And it brings together the current thinking and methodological research regarding COS development, implementation, evaluation, and updating. And there are plans to update the COMET Handbook in 2022. Okay, so as I mentioned, we have the COMET guidance, and we now look to see whether the core outcome sets that are published are citing this guidance. So in 2017, which is just after I think most of this guidance was published, just about a fifth of studies were citing at least one of these guidance documents. And then in 2018, this became 77%, which was great. But then in 2019, only 39% had cited at least one guidance document. Now, it could be that developers are aware of the guidance and using it, but maybe not thinking to cite it in their COS publications. It could also be that they're not aware, and so it's all well and good developing the guidance, but if people aren't using it, then we need to do more to promote it. So a variety of consensus methods are used to agree what outcomes are most important to measure. And there's no one, like a correct method. So as you can see from this table, the majority of studies, so over half, used a mixed methods approach. But one method which has been found to be pretty popular is the Delphi method. So up to 2013, only 14% of core outcome set development studies were using the Delphi method. This has risen to 60% of studies published between 2014 and 2019. And if we look at ongoing studies, over 90% are either currently doing a Delphi or are planning to use a Delphi during the development process. So agreeing the what stage, it typically involves a three-stage approach, and that is identification of a list of all possible outcomes. So this is often done through a systematic review of outcomes that have been previously measured. The next stage is to elicit consensus on which outcomes are most important. And as we saw from the previous slide, this is often a Delphi survey is used to do this. The final stage is holding a face-to-face consensus meeting to agree the final core outcome set. Okay, so I mentioned on one of the previous slides about the COSTAD minimum standards. So what we do now, since the publication of the standards, we look to see how many of the core outcome sets are meeting these standards. And in 2019, we found that 18% met all standards for this what stage. So, which it's good that some studies are meeting all, but there's definitely room for improvement there. So there's 11 standards, 11 pieces of criteria within the minimum standards, and these are split into 3 domains. So we've got scope specification, stakeholders involved, and consensus process. So scope is pretty explanatory, so we recommend that developers specify the setting for which the core outcome set applies to, the health condition, the population, and the intervention. Because it's all well and good developing a core outcome set, but if no one knows who the intended audience are for it, the population, the intervention, then no one's going to use it. But it's great to see that in 2019, all of the core outcome sets met this scope criteria. The next domain is stakeholders. So there are 3 groups of stakeholders who are considered essential to the development of core outcome sets. And they include those who will use the core outcome set in research. So these are people like clinical trialists or industry representatives. Then we've got healthcare professionals, so those who have experience of treating patients with the condition. And then we've got patients, so patients have experience of the condition or their representatives. And as we can see, quite a high number of the 2019 studies met these standards, not as high as scope, but it's still pretty good. Then if we move down to the consensus process criteria, we can see that this criteria is not met as well as the others. And this includes things like the initial list of outcomes considering both health professionals and patients' views. So as I mentioned before, identifying the long list of outcomes, people often do a systematic review to find out what's previously measured. This often includes outcomes that are measured in trials, which may not account for patients' views. And so we advise doing possibly bringing in the patient perspective at the beginning through maybe qualitative work with patients or a review of qualitative studies on patient perspectives. Next, we recommend that the scoring process and the consensus definition are described a priori. And so scoring process, we're thinking of a Delphi, so 1 to 9, and consensus definition, i.e. 70% of each stakeholder group met, this outcome was considered essential. And to assess this, we need COS publications to either state that the scoring process and consensus definition was described a priori, or if there's a protocol, it should state within that the scoring process and the consensus definition what they will be. And we do include links to protocols in the COMET database as well. Then we've got the criteria for including, dropping, or adding outcomes should also be described a priori, so like the others. So that this is often like between rounds maybe of a Delphi. So if you're including or removing certain outcomes, you need to plan this from the beginning. And finally, it's recommended that care is taken to avoid ambiguity of language used in the list of outcomes. So when you've got that long list of outcomes, it's also recommended that you have a plain language description. So these outcomes, they could be, not everyone might know what they mean. They could be physiological outcomes that patients may not understand. So having that plain language description is really important. So there's definitely room for improvement in terms of the consensus process criteria. Okay, so what I've been talking about focuses on the what. So we've got 370 published COS studies that have identified what outcomes are most important to measure. The next stage, and an important stage, is the how. So of those 370 studies, just over a third have also developed the how. So they've recommended how the outcomes within the core outcome set should be measured. And in 2016, the COMET practical guideline for how to select outcome measurement instruments for outcomes included in a core outcome set was published. And so recently we've looked at the methods that have been used to select outcome measurement instruments of these 129 studies. And as you can tell from the title, these methods have improved since the publication of the guideline. So looking at the results on a whole for those published before and after, we found that 48% of studies used more than one source of information when finding outcome measurement instruments. So by sources, we mean things like could be a systematic review of measurement instruments, could be expert opinion, and so on. 74% perform some form of quality assessment of the measurement instrument. I should say this looks really high, but it could just be some discussion. Very few done a thorough quality assessment. 19% recommended one single instrument for each core outcome included in the core outcome set. And if we look at stakeholders, clinical experts and public representatives were involved in selecting instruments in 62% and 28% of studies respectively. So what are our recommendations for core outcome set developers who are doing the how? Well, basically utilize the COMET guideline to help you basically to do the how, or use other guidance such as OMERACT or HOME, and what they have available can also help. Also, make better use of the literature to inform instrument selection. So we found a huge proportion of studies relied on expert opinion alone, which is all well and good because you've got the right experts, but it's just a select group. And there's a lot of literature out there on different outcome measures, so make use of that. Next, we ask that you ensure that outcome measurement instruments are of sufficient quality. Now, sometimes not all developers have the resources available to do this, and so if you can just ensure that there's sufficient content validity, then that's a start. We also ask that you aim to adhere to uniformity by selecting a single instrument for each outcome within a core outcome set, because if multiple measures are recommended for the same outcome, you're going to get people measured in different ways, and you don't have that uniformity. And then finally, include more representative stakeholders. And this includes patients. A lot of developers will think that the how is just too much for patients, but it's really not. So when you've got a patient-reported outcome measurement instrument, you can bring patients in there to evaluate the content validity by assessing the comprehensiveness of the items within it. So there's always room to include patients within it. Okay, oh, sorry. And now I'll just hand back to Paula. Right, you should be able to share yours again, Paula.
Oh, let me try again, Sarah. I thought I had it then. Have you stopped sharing yours, Sarah?
Yeah, I'm viewing your screen. If you go back onto your slides, and then if you click go on to slideshow and just go from current slide or from beginning.
It's not liking it. Let me do it again. I may need to get you to take over, and I will. Let's just.
Yeah, they can do that.
We'll just see.
Do you want me to put them up and you just tell me when to move?
One more go, Sarah.
If you go to slideshow on the top in the orange.
I've got resume slideshow, but that's not working either. Okay, let's go with you.
Right. One sec. Sure.
Let's play a game, Sarah, and I won't actually tell you when to move forward. We'll just say.
I'll just guess. Make sure I'm paying attention. Right, can you see that?
I can, thank you. Okay, so as Sarah showed, actually core outcome set developers are now including patients in very many of the published studies, but in particular in the ongoing. So you can see how much things have improved. So it's no longer whether to include patients in core outcome set development, but rather how best to. So next slide, please. In response to that, COMET set up the POPPY group, which comprises both patients and researchers and patient organisations. And they have been developing a whole suite of resources to help developers. Next slide, please. I'm not going to steal their thunder because they are presenting the next in the series on the 20th of October. So please tune in then and you'll hear more about what POPPY have been doing, but also what they've been doing at the National Health Council in the US. Next slide, please. But one thing I did want to point out was this issue. So as Sarah showed, there has been a huge increase in the popularity of Delphi studies as part of the core outcome set development process. In fact, over the last 5 years, 2/3 of the published studies have included a Delphi study. And in fact, nearly 3/4 of those have included patients in that Delphi study. Of those, almost all of them in the Delphi study in round 2 showed the feedback by stakeholder groups for each stakeholder group separately. Now this work is as yet unpublished. It's part of Heather Barrington's PhD. Heather, you may know better as Heather Bagley. Heather's on the call and she's allowed me to show this. But her work as part of POPPY and COMET is all about trying to optimize ways to include patients in core outcome set development. But let me explain about the stakeholder group feedback being shown separately. Next slide, please. What I mean by this, ignore the fact that there are 4 histograms on this, 4 graphs on this slide. If you imagine a core outcome set where there's health professionals and patients being involved, then if you look at the left 2 graphs, what would be displayed in the second round of a Delphi would be, you would see the results that the patients have said for the patient group, and then you would also see the results for the health professionals, but they would be summarized separately and not pooled together, okay? And one of the advantages of seeing them separately and not pulling them together is that if you have differences in the number of patients from health professionals, you know, there's an amazing study from the Bristol group where there's something like twice as many patients as health professionals, but most often it's the sort of the other way around. It's typically the other way around. But even if you have this imbalance, you can still see the views of those groups separately. And actually, the reason for doing this was motivated by a really seminal paper that was led from the Bristol group. Next slide, please. That's here. And this actually showed from studies within core outcome set projects that if you do show results from the different stakeholders, if you show them separately but show the results to everybody, then it does improve consensus at that round. And to be honest, that makes complete sense, doesn't it? If you're trying to achieve consensus, even in a remote way through a Delphi, actually seeing other people's views in a different sort of peer group, in both your peer group but also a different stakeholder group, it allows you some insight into those other views. Next slide, please. Okay, so the title of the talk was not just about how developers are developing core outcome sets, but also what is the result, what's the content of those core outcome sets. So this is quite a complicated table for which I apologize, but this does reflect the 300 and whatever it is, 400 and something or other core outcome sets. Okay, you can see here, so these are all the sets that were published up to the end of 2019, and my thanks go out to Susanna Dodd, who may be on the call, who's another member of the COMET team, who has painstakingly extracted all of the outcomes in those core outcome sets and classified them using a taxonomy into domains. The columns with the red figures in indicate the core outcome sets where patients were involved. The black indicate those core outcome sets where there were no patients involved. So you can see if we look at each domain in turn, if you look at the domain of mortality, then all across the whole set of core outcome sets, 38% do include mortality as an outcome. If you look at the physiological enormous domain, enormous bucket that is physiological outcomes, then almost all the core outcome sets include something from the physiological domain. If you look at life impact, this is where you see the impact of patient participation. So 63% of core outcome sets that didn't include patients did include an outcome that you would list within the life impact domain, but that jumps up to 86% of those core outcome sets where patients were included. And if you look at the sort of subdomains of where that patient influence is appearing, it's both in physical functioning, where half of the core outcome sets, including patients, included an outcome within the physical functioning domain, but also emotional well-being. So patients are having an influence on the content of core outcome sets. If we jump to the right-hand side of the table, under the domain of resource use, then it's very similar. So about a third of core outcome sets include something around resource use. Adverse events. Now, this is a tricky one. Okay, this category is used, and it's about a third, and you'll probably be shocked by that. Only a third of core outcome sets are saying something about the need to make adverse events core. This domain is used where the term adverse events or side effects or toxicity is being used, so somewhat non-specific. If a core outcome set includes a specific adverse event associated with a particular intervention, such as a particular surgical complication, for example, that would actually be classified under the specific domain, such as the physiological domain. So things are not quite as bad as they look, okay, but there is absolutely a need for core outcome set developers to focus a bit more on the adverse events. I can say more about that if we want to at the end, but that is something to be aware of. Next slide, please. Okay, so we've mentioned patients and the importance of including patients as stakeholders, but equally important is to think about where in the world your stakeholders are coming from. So if we really want core outcome sets to have an impact, we know that research is undertaken globally, around the world. COVID-19 research is being undertaken everywhere around the world through need, unfortunately. But what we see here on this slide, this is showing the percentage of published core outcome sets that have included people's views from those different continents. So you can see that the vast majority of published core outcome sets involve views from people in North America and Europe. And there is a severe underrepresentation from those in South America and Africa. The situation was severe in Asia, but there has been a tremendous increase in the involvement in core outcome sets from people in China in particular. I know some of those core outcome set developers are on the call today. So things have improved a little bit, but there's a huge amount of work to be done here. Next slide, please. Okay, I'm just going to turn a little bit away from the methods of core outcome set development for a minute, but just to say that COMET started in 2010 and was really focusing on the ET, standing for effectiveness trials. So people involved in COMET were coming from Cochrane. We were seeing the problems firsthand. We were, wanting to try and overcome the problems in trials that would inform decision making. But just as clinical trials are only as credible as their outcomes, thanks to Peter Tugwell for that fantastic quote, that phrase is a statement is equally true for systematic reviews and also clinical guidelines and also healthcare organizations. So anything that you do on which the basis for making decisions is health outcomes, you will find that there's a similar sort of problem, inconsistency and who's deciding what to measure. Next slide, please. So it's interesting then that when we did a pop-up survey that many of you may have been irritated by, at least half of you were probably irritated by it. We ran a pop-up survey last year for 4 weeks. 50% of people clicked the pop-up survey button immediately, but 50% did give us their answer as to who they were, why they were searching the COMET database. And what's interesting here and what's different from the survey we ran at a similar time 3 years previously is if you look to the middle of that table, you will see 34 people who were planning a systematic review of clinical trials were looking at the COMET database. Further down, you'll see that 18 people were developing a clinical guideline and 7 people were auditing a condition. So clearly, this database is not just being used by people who are developing core outcome sets and they're checking whether somebody is already doing it. It is also being used by people who are wanting to use a core outcome set, but not just clinical trials or funders of clinical trials, but now systematic reviewers, clinical guideline developers, and even people auditing routine care. Next slide, please. If you want to find out the sort of organizations who are promoting, endorsing core outcome sets in the COMET database, then you can go onto the website. There's a growing list of trial funders. Next slide, please. But there's also a growing lots of different stakeholder organizations, whether it's funders, whether it's clinical guideline developers, journal editors, etc. Next slide, please. We're realizing, though, that it's not as easy as one might think for a user to come to the database, to find a core outcome set in there, and to decide, is it relevant to what I want to use it for? Is it relevant to my trial? Is it relevant to my review? Is it relevant to my guideline? But also to then assess how well was it developed. Next slide, please. I am not going to ruin what will be a fantastic webinar on the 19th of November, which goes into this in a much more detail. So COMET early on was focusing on how to develop core outcome sets and promoting people to develop core outcome sets. Over the last couple of years, we have definitely focused much more on how to promote the uptake of core outcome sets. And there will be a webinar showing various studies that have looked at how well uptake is in various different arenas. Next slide, please. So just to finish off on a few things that COMET is also noticing from its work in the database. Those of you that were at Howell's session yesterday, opening the series, will remember he showed his diagram about the research ecosystem. This is a diagram about the research ecosystem. It's not quite the same. It comes from Holger Schoenemann's solar diagram. He's keeping an astronomical spin on it. But what you can see in this diagram, starting at the top with the trials, you can see it shows how core outcome sets may be relevant through from trials to systematic reviews to health technology assessments, through to clinical guidelines, and round through to routine care and quality improvement programs. This is an open research question as to whether or not we can find core outcomes that are relevant throughout this ecosystem. But what we have noticed, if you look at the top left-hand corner, of studies that were published up to the end of 2019, 12% of them purported to be relevant for both research and practice. So 88% were core outcome sets being developed for research. The other 12% were being developed to be applicable to both research and routine care. If you look at the ongoing studies that we have now, over half are being developed to be relevant to both research and care. That is a huge jump. Do we have the evidence that it's possible to get a single set that's relevant to both? Next slide, please. Well, if we look at the methods that core outcome set developers are using when they're developing a core outcome set for practice, here on this table we have two types of core outcome set. So these are not the classical core outcome sets for research that COMET has typically focused on finding in our systematic reviews. There's a group here which is core outcome sets for practice only. And then this 12% where the core outcome set has been developed for both research and practice. And my question of interest was, those of you that are developing core outcome set for research will typically, when you start to find your candidate list of outcomes, you'll probably go to the research literature. You'll have a look at what's already been measured in trials. You will hopefully also ask patients, but you will look at those trials. Here we're looking at core outcome sets for practice. How many developers went and had a look at what was actually being measured in practice? What was feasible? What was in the patient databases, the patient registries, the electronic health record? Were they looked at to inform the initial list? And you can see here that not very often. So yes, in about a third of cases where the core outcome set was for practice only, something about routine care outcome data collection was looked at, but it's a lot less when you're trying to develop it for core outcome set for research and practice. And I think this will have detrimental impact on the implementation of a core outcome set in routine care. I know from work that a PhD student is doing that it is very hard to introduce new outcomes into routine care. It's not impossible, but you need to be familiar with what is already being measured to know how much room there is in the system and whether you're talking about a replacement strategy by bringing something new in to replace something that's already being measured that may not actually be that valuable. Next slide, please. So what else is new from the COMET database? So we have, as Sarah alluded to, we are going to update the COMET handbook in 2022. Actually, when it was published in 2017, it was probably already 18 months out of date by then. And I'm pleased to say there's been a lot of methods research since then, because there is no single standard method that might apply. If you're involving children, the methods will undoubtedly differ from if you're involving people with early onset dementia, for example. So there won't be a single standard method, and we do need more methodology, more research around the methods, but we do have a separate category for those papers now in the database. As Sarah showed, a third of people have developed how to measure those core outcomes, but the other 2/3, we want to encourage people to finish that stage, complete that stage, and we want to register the protocols for the how stage as well. And maybe not necessarily for this audience, but certainly for the health technology assessment organizations, the clinical guideline organizations. I'm pleased to say that we've developed an alert system. I've just tested it this morning, that will let those organizations know when something new has either been published or registered in a health area that they're interested in. And it may even be that if you're a core outcome set developer and you would like somebody from one of those organizations to be involved in your work, well, you can add that to the registration form now, and we will try to match make with the people who are using our alert system from health technology assessment agencies, as an example. Next slide, please. I'm actually going to very, very quickly, simply to let you know that the COMET database does hold information on core outcome sets for studies related to COVID-19. So there were studies undertaken very early on in the year to develop core outcome sets for the treatment of patients with COVID-19. And if you go to the next slide, please, Sarah. Sorry. I just want to do a major shout out. I mean, it was fantastic work that all 4 groups did. We kind of coined this term meta core outcome set because we looked across those 4, and there are 2 outcome domains in common for all patients who are hospitalized with COVID-19. But a particular note of praise for Alison Tong, the study in the 4th column, it has been accepted for publication because they managed to involve 4,500 patients and members of the public in their Delphi. It can be done, unfortunately, in such a situation, but it can be done. Next slide, please. So to finish, I'm sure you're already aware, that's why you're probably here, of the problems with outcomes in trials. There are some development standards that exist, some minimum standards, but that doesn't mean there's a single method that we're recommending. We actually want plurality of methods, and we do want comparisons between them. That will be really valuable. Hopefully you've seen that there are several different organizations that could have a role here, but we absolutely definitely need strategies to increase core outcome set uptake. But to hear more about those strategies, then you need to tune in on November the 19th. Thank you. So, Sarah, have you managed to monitor the chat, and are there questions that we need?
There's definitely questions. I didn't have a chance to look because I was sharing the slides, and I didn't want them.
Let me scan down and see. Okay, Sally Ann, do you want to?
Oh, sorry, I'll just allow people to unmute. One sec. There we go. So you should be able to unmute yourself now.
Hello. Hi.
Hi, Sally Ann.
Hi, Paula. How are you?
Good,
hi, Sarah. No, my question was just really, was COMET the only international registry? So somebody's already answered that, which is great.
Okay. As far as we know, we should always say that, shouldn't we? As far as we know, yes.
Brilliant, thank you.
Okay. Let me see. Okay, I can see. I'm looking for where questions haven't been answered. Okay, can I go to Ruala?
Hi there. Let me see. Hi, I actually need to run to clinic 2 minutes ago, but I was talking to people who have been developing core outcome set and moved on to the how, just, you know, people you meet here and there. And from their perspective, it seems that when you adopt the COSMIN steps, it could be a little bit harder, or it's quite hard for people to grasp how to choose the instrument. I haven't done the process myself. I am planning on doing it in the next few months. But I was just asking in general if people have experience on how to involve clinicians who might not be aware about the fancy things like content validity and all these new words I am learning myself now, and I've been a clinician for 14 years. So how do you involve healthcare users and clinicians so that they understand the process and you get the most out of it from running it?
Before I answer that, Rala, I would make a couple of comments. So one thing is, I think it's really important, particularly at that stage, and possibly from the beginning, that wherever possible, you try to involve somebody who is a psychometrician. Okay, there aren't very many psychometricians around. Clinical epidemiologists are great too, but this is a challenging area. What I would also say is that Caroline Tovey, who's probably the best psychometrician I know, leads COSMIN. She's also a pragmatist. So whilst those guidelines, are, if you've got lots of time and lots of resource, that's the gold standard. But as a pragmatist, she would also say you may find something like, if you're looking at quality of life as a domain and you want to find the best instrument, when you go to the literature, you may actually find there could be 15 or 20 different ways of measuring quality of life. How do you have the time to do a systematic review of all the psychometric properties of each of those? In that situation, you may want to simply look at the ones that really have been used the most frequently. Okay. Now, that isn't necessarily always the best way to do, but it will at least give you an idea that those are feasible, that those instruments would meet the feasibility criteria. So I think we're learning on this stage of how to do this, and it will vary, depending on the condition. But I think it needs time. And what we find is, whilst people register to do the what and the how, and often they register to do that all within one PhD, that is a challenge. Okay, so the important thing to say is we want core outcome sets to not be a one-off. Okay, ideally, core outcome set developers, we want them to link into bigger groups who can make sure that the work carries on, even if somebody finishes their own part of it. But it doesn't just stop there, because we do recognize it can take time to get from both the what to the how.
Yeah, you almost need a detective, don't you, to just make sure they follow the process through and tick the boxes. But also what someone alluded to earlier on, I don't know if it's Sarah or you, about making sure the uptake in clinics is effective, and how like charities measure outcomes of their funding and all of that. So it's all a constant challenge, but as you're saying, like contributing to the literature and our learning from what we've done also helps. So yeah, thanks a million. I need to run. It would be good to get the recording of this.
Yeah, it will be available. Sarah will let everyone know. Bye, Rala. Katie, do you want to? Katie Gillis?
Hello. Thanks, Paula and Sarah. That was a great update and lots of work being highlighted. So thank you, and well done for getting all of that in there. So somebody raised this question earlier on, and it got me thinking as well. So it comes back to this idea about inclusivity. So we know at the moment that many trials aren't as inclusive as they could be, and often that the populations who they are including in their trials aren't necessarily representative of the populations who the evidence aims to serve. So I guess, Sarah, to you, is there any sense of all that huge amount of data extraction you've done on core outcome sets? Are people reporting ethnicity in terms of the patient populations that they're involving? And then do we have a sense of whether that actually matches? Because what core outcome sets could start to do is actually address some of the gap, because if your trials are consistently measuring outcomes that are only important to one cultural group, but you do some core outcome set work and identify, well, actually, you know, mortality is going to be important to everyone. That's not a good example, but some other outcomes are important to other groups over others, but you could include that in the core outcome set. So it's not about whether it's representative in other countries, it's whether it's representative of the population.
Yeah, we don't extract those details when we do the data extraction. Have looked in the past, and as you said, it's not great what people report. I imagine more recently it has improved, but we add on to the data extraction each year. So anything that's considered important, we'll then start data extracting it. So it is a good point. We could do that, and to be honest, it wouldn't take that long to extract that information with everything else that we're looking at as well.
So I'm just going to see if Heather wants to come in here, because she has actually been doing that for the studies that included patients in Adelphi. Just before, if she's still here, this is just for Katie, and this is very informal. I do apologise, but this is a reindeer, and of course everybody knows that COMET was one of the best reindeers. Okay, so you might all think I'm completely mad, but Katie and I had quite a lot of fun yesterday discovering these background filters, so sorry about that. Okay, Heather, are you still there, Heather? Yeah. Would you like to say something about the characteristics of the patients who've participated in core outcome set and what you found in terms of...
I've not got my... Can you hear me?
Yes.
Yeah, I've not got my tables open, Paula, but basically ethnicity, very, very low numbers. I can't give you an exact percentage because I'm rustling around with my papers, but I am collecting data on what's reported in terms of both patients and professional contributors from the past, well, since.
That's great. And can I be really cheeky and ask one other really quick question?
It has to be really quick because I'm going to move on to Sheila Dickinson's, which is very interesting.
Okay, so it's about approaches to looking at implementation of core outcome sets. Is anybody using an implementation science approach to ask the question?
So do you want to tune in on November the 19th to Karen's talk? Is a very quick answer, Katie, and ask the same question if it's not answered. Can I move to Sheila Dickinson's question if Sheila's still here?
Hi, thanks. So I work for a pharma company. I work for Novartis. So I'm particularly interested in what do the regulators think about core outcome sets. And in particular, I think I've seen the FDA start to do some thinking about this, and I wondered if this is something you could comment on further, either FDA, EMA, regulators of any flavor. Thank you.
Okay, so that is a great question, and I'm glad you asked it now rather than say 3 years ago. Things I think have definitely moved. So when COMET started back in 2012, we actually had an international steering committee with Irmgard Eichler from the EMA on there, and she saw the relevance of core outcome sets to what the regulators were doing it sort of immediately. So the regulators, the EMA, don't develop core outcome sets themselves. They look at the literature, and on the basis of the literature, they will then bring that into their guidance documents. So I think it was 2016 that the first guidance we saw that referenced core outcome sets, it was in pediatric asthma. It's probably 2017 actually, referenced it. And certainly the EMA are aware of the relevance of core outcome sets. There's a nice podcast by Hans-Georg Eichler from the EMA on the COMET website. Now and what they do is whenever they issue a new guidance document, we have an alert and they ask COMET to look in our database and summarize back to them as a response to their consultation. So what we tend to do is try and find the core outcome set developer who might have done something that's relevant and get them to work with us to submit a response. So that's what we're trying to do with the EMA. Now the FDA, so recently, they have done a few things. So recently they put out a call a couple of years ago to do some sort of pilot work, a pilot scheme on developing what looks like core outcome sets. They didn't use that phrase and they use different terminology. So this, this is an issue, but they've definitely funded some work in schizophrenia and migraine and another condition I can't remember. And they're going to run that again. But I think importantly, they came as observers to the workshops that COMET organized over the summer on core outcome sets for studies to prevent infection with the SARS-CoV-2 virus. And they have recently issued a guidance document about symptoms. And although it doesn't refer to those workshops, they were helpful and helped inform the guidance. I know that in an email. So there's definitely much more interaction than there has been. What I would say, when Sarah referenced the core outcome set minimum standards for developing a core outcome set, she mentioned the 3 groups who where consensus was reached that they should participate. So that was patients, health professionals, and those who should use the core outcome set in their work, in their research, let's say. There was a 4th group, and that group was those who should use the research that should have used the COS. And by that, we mean people who are reviewing research studies, whether it's systematic reviewers, health technology agencies, clinical guideline developers, and regulatory agencies. Now that 4th stakeholder group didn't quite reach consensus. That was 3 years ago. I think if we ran that study now, development standards again now, it may well go in. The reason it didn't go in 3 years ago is it would be a bit silly to put a minimum standard in that was extremely challenging to meet. Okay, and it was quite clear that early on that people had had varied experiences of engaging HTA, regulatory bodies. So I think it's changing. It's definitely changing, and we're seeing much more interest. I think fueled in part by the increased interest in patients' views in determining the outcomes that are relevant. So the regulators have stated that, and FDA, have said that for several years. I think it's a natural progression from recognizing the importance of patients' views to then moving into where patients' views are coming forward, and they're definitely coming forward more frequently in core outcome sets. Sorry, that was a very long answer, Sheila.
Much appreciated. Thank you.
Comprehensive is a nice adjective to use. Now, are there questions that I've missed or comments? Martin,
Yeah,
I can see several comments, Martin. I don't know if you wanted to summarize.
Just want to say hi, happy Friday from Canada, and congratulations, Sarah and Paula, with going into the second decade of COMET. You know, I'm a great fan, and I think we're out of time. I just addressed a few questions there for people to click on a few links, and I'll be attending the next few seminars for sure. This is great.
Brilliant. We'll save the chat, and I think if we can, we'll put the chat next to the recorded video for people to refer to. Is that right, Sarah?
Yeah, I can do that. There was also one question from Hajar asking about any guidance on COVID-friendly online consensus meetings. So people have been in touch about that, and I have put people in touch with Alison Tong. So she developed the core outcome set for COVID-19 treatment. And we're actually, Paula and I, involved in one next Friday. Mm-hmm. But we're doing one online. So any tips or anything, but if anyone wants to email me, and I can try and put people together who've done it so far to give any tips or advice.
Yeah, I think that's what we thought we would do, was to bring people together who've got some experience, possibly also with people who are planning one over the next 3 to 6 months, because again, there's no textbook approach here, and some things seem to work better than others, but it will be context dependent, no doubt. But I think it's quite interesting that, you know, if we can get this to work, then it does offer what looks like a promising alternative to what could be a very expensive, even if feasible, face-to-face meeting. But, you know, we'll have to see if we can kind of get the best tips from people who've already tried this. That would be great. So we may put out a call to people who've done it and get them together on a call to share their experiences. Okay. I can see one. We are 2 minutes over time, so we might start to lose people. I could just see one last question from Milan. Did you want to? Are you still with us, Milan?
Yes, I'm here. I just thought that somebody was going to pick it up in the chat and comment on it. It was only a provocative comment, really. I was thinking of PPI. It's increasingly important nowadays in research grant applications. And I thought that that a core outcome set seems to presuppose the questions that people want to answer. Whereas if you made PPI a part of the grant application, you'd be consulting people straight away, asking them, what do you want measured? So I'm really going into the rationale of COS from the beginning rather than, you know, PPI from the beginning. But it could be that they aren't actually in contradiction, as you say.
I don't think they are. So one of the key things is, if you're developing a research project, I think it's fantastic that your first thought would be patient research partners, okay? And that one of your next thoughts is, and what are the most important outcomes to measure in this research project? You will have a particular question. There may be a core outcome set that is applicable to that question. And that core outcome set may have involved hundreds of patients, tens at least, from different places around the world, giving you probably a more generally applicable core set than perhaps your 1, 2, or 3 patient research partners may be able to give you. Now, I know PPI varies in terms of its degree, certainly in the UK. They don't have to be at odds. What I would say is that if there is an existing core outcome set, if it hasn't included patients, then absolutely your patient research partners should look at it and say, does this have any face validity with me as a patient? That's a really good exercise to go through. But even if it does have patient participation in the core outcome set, again, ask your patient research partners to look at it, to comment on it. There may be something that isn't quite applicable enough in that trial setting. So I don't think it's one or the other necessarily. One would hope that in the vast majority of cases, the views will be compatible.
Okay, thank you.
any experience that people have. That's one of the call outs on November the 19th is going to be to people who've actually tried to use a core outcome set in their research and use a core outcome set that somebody else developed. So we've got a lot of people who develop core outcome sets and they're also trialists and they use their own core outcome set. That's fairly straightforward to do. It's when you go to the database and find a core outcome set, what is the process for you deciding whether to use it? That's what we're going to show, you know, what's happened with that on November the 19th, and then how we might also improve things.
Okay, thanks.
Okay, well, I think we are a little over time, but we think we've answered all of the questions at least. And so I'd just like to finish. Thank you, Sarah, for helping me deliver this seminar. As I mentioned, the next one in the series is around including patients in core outcome set development, Tuesday, the 20th of October. Details are on the website. It is not too late to register. Thank you very much for giving us an hour of your time today. Nice to see you all. Bye-bye.
Thank you. Bye.